This part of the presentation will focus on developmental defects such as developmental dysplasia of the hip, or DDH, scoliosis, slipped capital femoral epiphysis, osteogenesis imperfecta, juvenile idiopathic arthritis, or JIA, and septic arthritis. So starting with developmental dysplasia of the hip, and this is when there is abnormal development of the hip that may develop at any time during fetal life, infancy, and childhood. So the femoral head is dislocated from its position in the acetabulum, and we do screen for this in the newborn period. So what's the cause of DDH? So the cause is unknown, but there are some factors that are believed to affect the risk of developmental dysplasia of the hip. So being sex assigned female at birth, it being the first pregnancy, having a family history of DDH, breech intrauterine position, high birth weight, joint laxity or loose joints, and then postnatal positioning, so swaddling that can be too tight and doesn't allow for the legs to move, or sometimes they're in ill positions, or ill positions of infants and their hips in wearable infant carriers. So now there are varying degrees of DDH. So dysplasia is the mildest form. This is where you'll have a delay in the acetabular development. The acetabular roof is oblique and shallow. The femoral head is in the acetabulum with no subluxation or dislocation. Now, subluxation is the largest percentage of developmental dysplasia of the hip cases, an incomplete dislocation. So the femoral head is in contact with the acetabulum, but it's displaced. Pressure on the acetabulum inhibits ossification and flattens the socket. Now, dislocation is the most severe form of developmental dysplasia of the hip. And this is where the femoral head loses contact with the acetabulum and it's displaced both posteriorly and superiorly. So essentially with DDH, the hip or the acetabulum can become deformed if this is not treated in a timely fashion. So diagnosis should be made in the newborn period if possible, because if treatment is initiated before 2 months, this achieves the highest success rate. There are multiple ways to diagnose based on physical exam, along with different diagnostics. So you have your Ortolani and Barlow exams or tests, which are most reliable from birth to 4 weeks. This is when the hips and knees are flexed at right angles. The middle fingers are over the greater trochanter and the thumbs are on the inner side of the thigh. If the head slips forward on pressure from behind and can be dislocated, this is a positive Barlow exam. If it's dislocated and can be reduced, this is a positive Ortolani test. And then you can be looking for the Galeazzi sign, which is when they're laying down in a supine position, and then the patient's feet are flat on the surface that they're on, and the ankles are now touching the buttocks. So if the knees are not level, then this test is positive, indicating a potential congenital hip malformation. Now, by 8 to 12 weeks of age, the Ortolani and Barlow tests are no longer useful. Adduction contractures develop at 6 to 10 weeks of age, and then the Ortolani sign disappears. At this time, the most sensitive test is limited hip abduction. Other signs is that shortening of the thigh on the affected side, which is, like I had mentioned, the Galeazzi sign. Then having asymmetric thigh and gluteal folds. For older children, you may see a limp or leg length discrepancies. And then the diagnostic that you can do are the ultrasound plus the physical exam in infants younger than 6 months, and then x-rays for infants older than 6 months of age. So we're not doing x-rays because they're not reliable in that earlier infant period, because ossification of the femoral head does not actually occur until about 4 to 6 months of life. So we need to use an ultrasound, because if we did an x-ray, you're not going to be able to see that femoral head until that ossification actually occurs. I already went over, but just a reminder and some visuals of the different signs for developmental dysplasia of the hip. This is just showing you the asymmetry of the thigh folds, and B, the limited hip abduction as seen with flexion, And then you can see the apparent shortening of the femur in trying to demonstrate the Ortolani and Barlow test. And then last is the Trendelenburg test. So again, this is looking for hip dysfunction with the Trendelenburg test. The patient stands on the unaffected leg and flexes the knee to a right angle. The pelvis should remain level or tilt up on the non-weight-bearing side. So this is then repeated on the affected side, where you would see the opposite thing happening, and the pelvis would tilt towards the affected hip, indicating weakness in the hip abductor muscles. So what are the clinical recommendations for developmental dysplasia of the hip by the American Academy of Pediatrics? So all newborns should be screened or are screened by physical exam. If the results of the physical exam are positive, so positive Ortolani and Barlow sign at 2 weeks, need to refer to ortho. If at the 2-week exam, the Ortolani and Barlow signs are absent, but physical findings raise suspicions, then we need to consider, again, referral to ortho or request an ultrasound at age 3 to 4 weeks. If the results of the physical exam are negative at 2 weeks, follow-up is recommended at the scheduled well baby periodic exams. So every time that they go in for a well exam for that first year of life, really should be looking for this. And then if there are risk factors, so if the results of the newborn exam are negative, but then need to look to see are risk factors, do they have risk factors, sex assigned female at birth, breech, positioning, and family history, just to name a few. So essentially, if any concerns, we're referring. Now, therapeutic management. Developmental dysplasia of the hip is treatable, so it's important to treat as soon as the condition is recognized, because then that's when it's going to be most successful. This is going to vary with the child's age and the extent of dysplasia. So for newborns up to 6 months, they typically will be in the Pavlik harness for approximately 6 to 12 weeks. And then if they're between 6 to 24 months, they often will have a surgical closed reduction in hip spicacast, and that's going to be on for about 12 weeks. And really the main goal is to maintain a safe, congruent position of the hip to promote normal hip joint development. So with the Pavlik harness, which I'll show on the next slide, with time, motion, and gravity, the hip works into a more abducted, reduced position. So this is something that needs to be worn continuously until the hip is stable, clinically and on ultrasound. So again, like I had said, it's typically seen or worn for about 6 to 12 weeks. So here is an image showing the Pavlik harness. And again, teaching would have to go along with this. So removing of the harnesses is determined on individual recommendation of the provider, the degree of hip instability, and then the family's level of understanding. So really, parents should not adjust the harness. This would be done on visits with the provider. But what we need to teach caregivers to do is to check frequently for any skin breakdown, looking for redness under the straps and in the skin folds. We can massage the skin under the straps daily to stimulate circulation. We want to avoid any lotion or powders as they may cake and irritate the skin. When we're diapering, making sure the diaper is placed under the straps and not around, because we don't want to inhibit the way that they're functioning. It's important to remember to encourage that they can be held, because the harness is keeping the hips in the position that they want. We want to make sure that we're holding them while we're feeding them. And you may see the red strap. Red is right. Red equals right. I'm going to mark where the straps were. When this is taken off, we know where and what position to put the straps when we put it back on. And often these infants are seen every 2 weeks with the provider to look for any adjustments that need to be made. If they are going to get dressed, to put like a shirt underneath to kind of help again with the skin and obviously keep them warm. When they're loosening straps, things to consider is to loosen straps one at a time to be able to get that shirt underneath. If developmental dysplasia of the hip is corrected on an older child, you're going to see them often placed in a hip spicacast post-surgery. So this is an example of a single spicacast. And I just want you to note around the diaper area, you'll see sometimes this could end up being tape. They look like they extended like the inside of the cast to keep it dry. But again, this is where you would do the pedaling. So doing the different pieces of the tape and folding them into or under like the cast and tucking the diaper in, mainly to keep the area clean and dry. And typically you'll see a diaper that's in and then wearing a larger diaper kind of over. So double diapering and then pedaling the cast to keep the area dry. Another thing to remember is when we're lifting these children, this bar is to keep the legs in that abducted position, but we need to teach caregivers not to move the patient by this bar. You may think at home, well, how are they going to sit? So some recommendations or suggestions would be get a bean bag, lay them in a bean bag when they're with, family, because that way they can conform to that and kind of sit up a little bit. But kids are pretty resourceful in these types of devices. Sometimes they end up learning how to move and kind of army crawl while they're in a hip spica. Then here's an example of a full spica cast. And I just like this image because then you see maybe child life or maybe the surgeon also put a cast on their doll. And you often do see that. And just a random fact, pink and green are the most popular colors of casts. So nursing care of a child in a hip spica, similar to your cast care, right? We need to assess for the skin integrity. We're doing our neurovascular checks. We're managing their pain. Education and support for the family. So harness placement and cast care, depending if they're in the Pavlik harness or if they're in the hip spica. We want to try to promote normal growth and development as best as we can. So still getting them involved in their activities as best as possible, even if they're limited in ways that they can move. On the next slide, I'll show devices that are used for car seat safety or safety in positioning in cars. And when you have patients that are in hip spicas, things to consider or some concerns are infection underneath that cast. So again, making sure they're not scratching under the cast, putting things in that cast. Again, that's a great collection area for Legos and food. We're worried about poor neurovascular perfusion, constipation, because again, they're not moving as much. They may be taking opioids. So we want to make sure we're increasing their hydration and fiber. And they may have loss of muscle and flexibility and strength because they are in this cast for an extended period of time. Now moving on to scoliosis. So this is the most common spinal deformity. There are complex spinal deformities in 3 planes. So you'll have lateral curvature and then spinal rotation causing rib asymmetry and then thoracic hypokyphosis or kyphosis. So hypokyphosis is when there is not enough rounding in the thoracic spine. So this may be congenital or developed during childhood, but idiopathic scoliosis is the most commonly identified during the pre-adolescent growth spurt. Treatment of scoliosis is determined by the degree of curvature and resultant growing time. So again, treatment is going to be determined or based on the magnitude, the location, and the type of curve, the age and skeletal maturity of the child or adolescent, and then any underlying or contributing disease process. So how do we diagnose scoliosis? So this is identified through a physical exam. A scoliometer can be used to detect the degree of curvature. If the curve is more than 10 degrees with the scoliometer, then a standing X-ray will be obtained to determine the degree of curvature. So scoliosis screening is most helpful during the growth spurt. So often females are screened at 10 and then 12 years of age, and then males are screened at least once when they're 13 or 14 years old. So we're doing the screening. We have them stand and bend at the waist so the trunk is parallel to the floor, and then let the arms hang freely. And we really want to get behind them level with their back to look to see any curvature. And this is called the Adams position. So in its early stages, scoliosis is called mild if the curvature is less than 25 degrees. A person of any age may have early stage scoliosis. And then it's considered moderate if the condition progresses and then the curvature reaches about 25 to 50 degrees. So scoliosis is usually confirmed by taking an x-ray of the entire spine, looking from front to back. And then treatment is going to be determined by the degree of curvature and the age of the child, or how much longer that they're going to be growing, as the scoliosis can become more severe if they have a lot more growing to do. And so the imaging here is just goes through the different defects of the spinal column and then your varying degrees of scoliosis. So here's an example of a scoliometer. And so to use, you want to gently lay the scoliometer across the deformity at right angles to the body with the marking centered over the curve. And then we're going to observe the reading to see what degree of curvature there is. General rule is to revert to a provider with a scoliometer reading of 10 degrees or greater. So then, as previously mentioned, treatment or management will be dependent on degree of curvature and the age of the child. So mild curves are those, again, that are less than 25 degrees, and we're going to observe. Moderate curves are between 25 to 45 in a growing child, and they're going to do bracing. And then usually 45 or greater, you're going to have a surgical intervention. So they're going to end up having a spinal fusion. Often you will observe these children with regular clinical and x-ray evaluations. And then if they use a brace, this is not curative, but it slows the progression to allow skeletal growth and maturity. So now here is an example of the TLSO brace, or the thoracolumboSacral orthosis. So this is something that doesn't cure scoliosis, but this slows the progression of the curvature to allow the skeletal growth and maturity. So although used as the gold standard for treatment for moderate curves, this is not proven to be entirely effective in the treatment of idiopathic scoliosis. So again, also remembering the age of a child that may be wearing this. So body image can be a big concern for these children. Now, for the more severe cases of scoliosis, these children will undergo a spinal fusion, which is a surgical procedure used to correct problems with the small bones in the spine or the vertebrae. It's essentially a welding process, and the basic idea is to fuse together two or more vertebrae so that they heal in a single solid bone. So some nursing considerations. Again, concerns for body image, concerns of prolonged treatment of the condition, and then for pre-op care, you'll see often an x-ray, maybe they'll have a pulmonary function test, and some labs, so your coags, your CBC, some chemistries, and a type-in screen or cross, since they typically lose a lot of blood with surgery. And then we want to teach them how to manage pain using a PCA and how they're going to roll or log roll after the procedure, and maybe talk about they may have a chest tube afterwards, or if they're going to have a Foley. So different things that they're going to see. And then post-op, checking skin, checking the surgical site, maybe having a pressure releasing mattress, teaching them and helping them log roll, looking at their surgical incisions, checking circulation of their extremities, and doing a neuro assessment. Again, we're going to monitor their vital signs, look for signs and symptoms of infection, potentially can have a pneumothorax that can occur afterwards, or potential superior mesenteric artery syndrome may occur days after surgery, because they'll have a duodenal compression by the aorta. So the superior mesenteric artery syndrome can result in complete or partial duodenal obstruction. Some clinical manifestations of this are epigastric pain, belching, nausea, copious vomiting, aggravated in the supine position. And then we want to do some pain management because they're going to have lots of pain. Most are walking by day 2 to 3 and then discharged within 5 to 7 days. Now, another condition that we're going to talk about or review is osteogenesis imperfecta, sometimes called brittle bone disease. So this is the most common osteoporosis syndrome in children. It is a rare inherited connective tissue disorder with many phenotype presentations. There are 11 different types, and these are classified based on clinical features and inheritance patterns. So those that are more severely affected will suffer excessive fractures and bone deformities with no trauma. So infants with the most severe form of osteogenesis imperfecta will die in the perinatal period. So milder forms may present with premature osteoporosis or severe postmenopausal bone mineral loss. So osteogenesis imperfecta should be considered if a patient has bone fragility and any of the following signs and symptoms. So if they also have short stature or bone fragility and scoliosis or skull deformities or blue sclera or hearing loss or teeth that wear quickly, increased laxity of the ligaments and skin, Wormian bones, so small irregular bones along the cranial sutures, and then if they bruise easily. So diagnosis is made based on and more straightforward in children that have bone fragility and then a positive family history of extraskeletal manifestations. So if those features are not present, the diagnosis can be more difficult. So there is no definitive lab test for osteogenesis imperfecta, but there have been advances in molecular genetic testing. So management of osteogenesis imperfecta is mostly supportive, focusing on decreasing the number of fractures and pain management. And then physical therapy or assistive devices such as splints or braces may be used to help support and then strengthen muscles and prevent fractures. There are a few medications such as biphosphonate therapy and pomidronate IV therapy that help promote increased bone density. So when caring for a child with osteogenesis imperfecta, careful handling is necessary to prevent fractures. For example, they do need to be supported when turned or positioned. If we're changing their diapers, we really shouldn't be holding their ankles because those with the more severe form, this can cause a fracture. Although fractures can occur, it really still is important to hold these children, especially in infancy, but we just need to be more cautious when we're holding them or moving them. Now, juvenile idiopathic arthritis, or JIA. This is a chronic childhood arthritis. It's an inflammatory disease of the joints causing irreversible articular damage. The cause or etiology of juvenile idiopathic arthritis is unknown, but the peak onset is usually seen in children 1 to 3 years of age. Some signs and symptoms that are seen in juvenile idiopathic arthritis are swelling and loss of motion in the affected joint. The affected area may be tender to touch and feel slightly warm, but there are times that pain is actually not reported, even though there may be a large effusion. Another characteristic symptom of JIA is morning stiffness of the joint in the morning or after periods of inactivity. There are various types and variable manifestations based on the number of joints involved, stiffness, joint swelling, and varying degrees of pain. Diagnosis of juvenile idiopathic arthritis is a diagnosis of exclusion. There are no definitive tests to diagnose, but classifications are based on onset of age prior to 16 years old, arthritis in 1 or more joints for 6 weeks or longer, and then exclusion of other causes. There is no cure for juvenile idiopathic arthritis, but treatment goals include preservation of joint function. We want to help them use them. We want to prevent joint deformity and help relieve symptoms without causing new ones. Treatment of juvenile idiopathic arthritis will be based on the classification of how many joints are affected. Medications we will see are NSAIDs such as naproxen or ibuprofen, disease-modifying anti-rheumatic drugs such as methotrexate and sulfasalazine, biologic disease-modifying anti-rheumatic drugs such as infliximab, and then the use of glucocorticoids. These medications are used based on severity and then type and escalated for severe disease. Other things to consider in management are using heat and exercise because we want to be encouraging movement to the affected areas, getting physical therapy and occupational therapy involved, encouraging regular rest periods, and again, encouraging exercise and splinting of the affected areas, nutrition, which will help allow for joint healing. And then we want to attempt to have them maintain normal life patterns. We want them to play, act, be a child, go to school, engage with their friends. This is just an image of affected hand joints. So with septic arthritis, which is also called suppurative or pyogenic or purulent arthritis. And this is a bacterial infection in the joint. So this may result from an extension of a soft tissue infection. May involve any joint, but most commonly seen in hips, knees, and shoulders. An infection in the hip is a surgical emergency because we're worried about compromised blood flow to the femoral head. This usually does only involve one joint. The most common organism, or the common organism causing the infection, is Staph aureus. And you often see it's community-acquired MRSA is the common cause of septic arthritis. So clinical manifestations that you would see to the affected joint would be warm, tender, they can have pain and swelling. It can follow, or often in the history, you'll see that it follows a traumatic injury. They will have fever, can see leukocytosis, and then increased sedimentation rate. Diagnosis of septic arthritis is based on results of a blood culture and then joint fluid aspirate, gram stain, and cultures. So now, depending on what organism is present, then appropriate IV antibiotics will be ordered. And then you'll have surgical intervention, which may be needed if there was a foreign object or penetrating wound involved. Physical therapy may be needed for a child that is immobilized, especially for septic arthritis of the hip, in order to prevent flexion contractures. So that ends this portion of the presentation.